had a shunt malfunction. So we looked at 100 consecutive shunt revisions in 68 patients, all of which had proven intraoperative diagnosis of shunt malfunction. And then we said, wouldn't it be interesting to know what the CAT scan said prior to the intervention. And so I looked at the prospective scans that were done before surgery and found that a quarter of them had words such as stable, normal, unremarkable, small, which implied that the shunt is working. And then 9 more, so up to a third of these patients had really misdiagnoses. So by looking at the CAT scans in these patients, you would not be able to tell that the shunt is not working, which meant that the ventricles may not dilate when the shunt fails, or may not dilate up to 3%. You can imagine if a child with shunt and community nutrition gets said, well, this is fine. Will be comforted with this and think that the child is okay, whereas they may be missing a major shunt malfunction. So with that in mind, of course, the solution is to have routine follow-up to teach not just the primary caregivers, but the family, that you cannot necessarily rely on CAT scans. To do this, you have to have routine follow-ups. You have to have multiple conversations, familiarization with our clinic, and routine communication, and all of that under education. So education is what improves the care of the shunt patient in these circumstances. So as we were taking care of these children, we started wondering that cancer risk, child, especially in a young child, 0.07%, which means there is 7 risk of cancer. Which means that 500 children will die of cancer related to that single CT scan. And of course, our children get frequent imaging of their heads because of shunts. So I approached our neuroradiologist, and together we developed, we didn't develop technique, we actually borrowed the technique from fetal imaging. It's called single shot fast spin echo, otherwise called quick brain MRI, and decided to try it on our patients. So this MRI takes less than 15 seconds to do, the whole scan. There is minimal motion artifact. When the child moves, unlike a CAT scan, the images are not blurred. There's no sedation required because it's so short. There's minimal sedation complications, as you can imagine, and excellent resolution in plane. More importantly, there's no radiation. So this is one of the children that I take care of with hydrocephalus, and he's laying in the MRI scan, and this is what he's doing in MRI. He is moving all over the place. He's not sedated, and he is continuously moving. And these are the images we've obtained: sagittal, axial, coronal. All the radiology tech had to do is center the images, because since the child is moving, one image is up in the corner, another image is in lower corner. So all they had to do is center the images, and this is the scan that we've obtained. So when we first published this, there were 131 MRI scans in an 18-month period. And what we found is in 11 children who had an average of 4 scans per year per patient, we've decreased their radiation risk by 0.25%. And in our most problematic child who had 10 MRI scans that year, we decrease the risk by almost 0.75%. So how do we think about shunts these days? Well, we want to minimize malfunctions to prolong life and enhance quality of life. There are many diagnostic tests, none of which is 100% effective. And there are complicating factors that make diagnosis much more difficult, such as developmental delay and follow-ups, multidisciplinary clinic visits, all under education. Okay. So what about now? Despite all the improvements in technology, shunts continue to fail. They fail a great deal. We don't know why. There's very high morbidity when they fail. There's a lot of headaches long-term. The families are always fearful, and the surgeons are frustrated. Is it acceptable that in the era of iPhones, Google cars, and sending missions to Mars, that we have no adequate valves that will mitigate the shunt malfunction rates that we see now? There's no understanding what shunting does to the brain, whether compliance, cellular damage, what causes the headaches, what causes the malfunctions. And here are the data. The chance that a first-time shunt placement will fail in the first year of life is nearly 40%. And by the second year, almost 50% of shunts would have failed. And the majority of these failures are related to problems with the ventricular catheter. So we decided to look at this. And the reason for that is, if you imagine that when you go to buy a car, the car salesman tells you, oh, by the way, there's a 40% chance that your car is going to fail in less than a year, and you're going to have to buy a new one. So, and by the way, a $40,000 car is not more expensive than revising a shunt. In the US, a shunt revision will not cost you any less than $40,000 between hospital stay, radiology, anesthesia fees, surgeon's fees, etc. But if a car company told you this, the car company would go out of business very quickly because it's unacceptable. But it's acceptable that we have shunt malfunction rates in the order of 40% at 1 year, and we're not able to find a cause or a solution despite outstanding technology that we have these days. We ran a survey of the American Society of Pediatric Neurosurgeons, which is our senior society. And what we found is that no one can agree on the cause of proximal shunt obstruction. Sometimes some people tell you it's reactive, inflammatory. Others tell you it's the choroid plexus. Others tell you it's the catheter position, it's the small ventricles. What we do know is two things. First, type valve, whether you have an Orbis Sigma or a flow-regulated valve, it doesn't matter. And catheter position doesn't seem to matter that much. Our hypothesis is that proximal shunt obstruction is a consequence of chronic shunt overdrainage. And I'm going to take you through a pictorial here, an illustrative approach as to how we came to that conclusion, just so that you understand what this is all about. So this is an endoscopic shunt revision. Here, there's an endoscope going inside the shunt catheter, and it goes through a hole at the tip of the catheter to look inside the ventricle. Here is a shunt endoscopy outside the shunt catheter into the track. So nowadays, we can revise shunts with very minimal morbidity on the brain We are very precise in how we position the catheter. We go through the same track so that we don't injure more brain tissue. We can do all of this now with endoscopy very safely. So what I'm going to tell you is that since most of the shunts that we do in Wisconsin are endoscopic, we started to find that the way that the catheter fail seems to be when the catheters stick at the tip of the catheter, and then tissue start to work itself into the shunt holes, into the ventricular, the catheter holes. So I'm going to show you a few examples of what we found. So if you imagine the endoscopy after you remove a shunt catheter, this is what you see. That's the ventricle. And what you find is that there are ventricular protrusions, these, in the areas of previous ventricular catheter. These are very orderly. It's like a row of trees. When we first observed this, the implications were not clear. However, it was thought that maybe these have a role in shunt malfunction. So the catheter would be replaced in a different area in the ventricle. But as we began to observe more closely, we found that these ventricular tissue evaginations, or ventricular bands, as we started to call them, are very common in cases of proximal shunt malfunction. In fact, they occurred in a majority of our proximal shunt malfunctions. So to date, we have, or at least when we published this paper, we had 70 patients with confirmed ventricular band findings, and all of these patients had proximal shunt malfunction. And as we had initially suspected, later endoscopic evidence showed that these correspond precisely to the holes in the catheter. They only occur where the catheter have holes. So in this video, we put a rigid endoscope next to the catheter, and as you can see, the small protrusions occur right at the site of the hole in the catheter. So the next question was, what causes these protrusions? Is it tissue growth? Is it migration, inflammation, suction? It's hard to tell. Well, it turns out that these tissue protrusions seem to form primarily due to suction through the ventricular catheter. Here, you see tissue in close approximation with the ventricular catheter. There's a small amount of flow through the endoscope. Now, I've disconnected the catheter from the valve. Whenever I occlude the catheter with my fingers, the ventricular pressure goes up, and these ependymal tissues get away from the catheter. However, when I let the catheter drain with gravity, just like you saw here, the tissue will start to be sucked into the holes. This suggests that suction through the catheter is the primary etiology of these ventricular bands. Then we started to appreciate the full spectrum of ventricular band findings. It appears that some are more advanced and may stick to the catheter. And the only way to get rid of them is to coagulate them and tear them apart like we're doing here. So they're stuck inside the catheter. And if more severe obstructions occur, such as in this image, often acute cases that require emergent surgery, there's extensive tissue growth around the catheter. So the image on the left shows reactive growth into the catheter. And to untether these catheters, electrocautery surrounding the catheter is often used. But during this process, we noticed that ventricular bands tissues extend into the drainage holes and sit inside the catheter and obstruct it. And this obstruction you cannot get rid of from the outside of the catheter. You have to remove the catheter and replace it. So one thing that you start thinking, well, if this tissue is growing into the catheter, that means the ventricles must be small. Do all these patients have slit ventricles? And we found that no. When the shunt is malfunctioning, some ventricles are small, some ventricles are large, some ventricles are asymmetric. But what we did find is that if you take all of these same patients and look at their scans when the shunt is working, they all have small ventricles, which means that these tissue protrusions or ependymal bands are growing into the catheter when the shunt is working. And then when we took it one step further and decided to look at the tip of the catheter. And the tip of the catheter in this case, for example, is sitting inside the ventricle where surrounded by spinal fluid, whereas this one is attached to ependyma, and this one is completely enclosed in ependymal tissue. So these class 1 CSF catheters that we call them, the tip is surrounded by CSF. We have not had any one of these fail. All of the failures were in class 2 and class 3, which tells you that you don't even have very small, you don't even have to have very small ventricles for the shunt to fail. All you have to have is small ventricles around the tip of the catheter. So what does that mean? That means that you have 3 types of ependymal bands that can form. Early on in the process, when it's still soft ependyma, is still a nicely compliant ventricle, suction causes the ependyma to close against the shunt catheter and tissue grows into the holes. The moment the pressure goes up, the ventricles dilate and the catheter is no longer occluded. This is likely what's causing the slit ventricle syndrome that we see every once in a while. However, when you have longer, older patients who've had the shunt for much longer periods of time, then these ventricular bands start to get stuck inside the catheter. Some of the holes may be obstructed, some of the holes may not be. Some of these shunts could be working, some of these shunts may not be working. But then if you wait even longer and there's additional suction that occurs, this is when the ependymal bands grow into the catheter and break off and lodge tissue within this catheter to occlude it. And there's your 2 in the morning shunt revision. The ventricle could dilate, but even ventricular dilatation is not going to unplug this shunt because now the tissue is sitting on the inside. So our hypothesis then is that shunt overdrainage causes small ventricles, at least the part of the ventricle that sits around the tip of the catheter. That causes ependymal bands that grow into the holes and that obstruct it either temporarily or permanently. Now, in order to prove such a hypothesis, we have to test whether decreasing suction, decreasing flow, improves shunt malfunction rates. And so what we've done is we've taken patients who have a shunt, and when the shunt failed, we added an anti-siphon device away from adding resistance to the shunt system. And I'll show you a picture. So this is the primary valve, and this is the anti-siphon device that we're placing to decrease the flow from the shunt system. Now, of course, if your primary valve is in the coronal region, you can put the anti-siphon device in the occipital region. The idea is to separate it by at least 10 centimeters. And these are the data. In patients who've not had a lot of shunt revisions, we cut down on the shunt obstruction rate or proximal shunt obstruction rate by 70% in the first year and by 43% in year 5. Now, these are patients who've not had a lot of shunt malfunctions in the past. However, if you take the really complicated patients, we call them complex patients, and each of those had at least 10 shunt revisions in their lifetime. The results are even better. What we find is at 1 year, there's an 80% decline in shunt obstruction rate. At 5 years, 65%. This is Richard. This is his high school graduation I went to a couple of years ago. Richard was born a triplet, and he was the only survivor. He came to me after he had had many shunt revisions at outside institution. And then even with everything that I've tried, I could not get his shunt to function properly. So by the time he was a teenager, he had had 150 operations, which was, unheard of. It's something that was unacceptable to us. We added his anti-siphon device into his shunts. He has 2 shunts, and we added an anti-siphon device into each in 2008, and he has not had a shunt obstruction since then. Now, this is an extreme example, but it shows you that there is really good possibility that shunt overdrainage is what's causing these kids to fail so much. It's true that shunt saved lives, but by saving these lives, we've also subjected them to chronic CSF drainage that's way beyond what they need. So if you can think about it like the reservoir is overflowing and you want to just trim off the top, you want to get rid of the excess fluid. Well, what shunts do is they empty the reservoir. So we're thinking, not only are the ventricles collapsing, the brain is drying out, becoming non-compliant. The skull is becoming smaller when the patient's shunted early in life. And when you ask the pediatric neurosurgery community in North America, how many of you think that the majority of your patients suffer from chronic shunt overdrainage? Less than 10% of them feel that way. So it is an under-recognized problem. It's a problem that we feel is significant, but that is not being considered yet by the research community, by the shunt industry. So we decided to build a valve system that could potentially improve this. But before we do this, we have to understand the physiology a little bit better. So as we all know, gravity is a major cause of why shunts drain. And we feel that gravity causes overdrainage. However, when we simulated our shunt systems and then we did some benchtop testing, we found that gravity is not the only mechanism to overdrain shunts. There's another mechanism that can happen even when you're in the supine position, and that is pulsations. So you can imagine that if you're laying in bed and then all of a sudden you start to cough, every cough is putting a lot of pressure in your brain, 50, 60 millimeters of mercury, which far exceeds any shunt valve mechanism that is available on the market, which means that every time you cough, you're going to drain way beyond your average ICP. If you're going to have a bowel movement, if you're going to be watching TV, climbing upstairs, climbing downstairs, all of these are instantaneous pressure elevations that drive fluid into the shunt system way beyond the capacity of the valve, which means that people with shunts have overdrainage not just in the sitting or standing positions with gravity, but also in the supine position because of either Valsalva or even cardiac pulsations. Imagine a systolic pulse. Every time there's systole, there's more pressure, more fluid driven into the shunt system. The way you can simulate this is, this is in San Francisco. This is called Half Moon Bay. And right here, this is a wave breaker that was built to protect the shoreline right here. So what does a wave breaker do? Well, look at the shoreline here. There are waves that are constantly breaking on the shore. And every time a wave breaks on the shore, it destroys part of the shoreline. However, when you build a breaker, those waves are breaking on the wall, and then the water can streamline. When it's streamlined, it enters nicely into the bay, so it doesn't destroy the bay. And you can see shunts as they are nowadays, shunts without any protection from these instantaneous waves, whether related to pulsations or gravity, that are causing overshunting. What we do need is we need some kind of a breaker on those valves. So this is what cardiac pulsation waves look like. This is what an existing valve looks like. So for example, let's say an existing valve is supposed to maintain an ICP of 10 in the brain. Because of the instantaneous pulses, the ICP keeps creeping below that average, so that it ends up being -5 instead of being 10. However, if you have a smart valve, a valve that doesn't open whenever there's an instantaneous pulse, but only opens based on average ICP, then the ICP that you reach in the brain will be the ICP that you set on the valve system itself, which means that you need a valve system that's going to measure the ICP, average it over a number of minutes, and then open the valve. But at baseline, that valve is closed. And this is the valve system that we've developed. It has an ICP sensor with a flexible antenna. It has a valve driver. It's a bunch of electronics that takes the ICP, averages it, and sends it to the valve. And this is an on-off valve, which opens only when the driver tells it to open. The whole thing is controlled by your cell phone, by an RFID device, and the battery is charged in the same mechanism. You can imagine an RFID device a meter or two away, maybe on a pillow at night or at your bedside table, that recharges the valve overnight. So the hypothesis is that overdrainage is the cause of proximal shunt obstructions, which is the majority of shunt obstructions. It's important to minimize the flow through shunt system to improve the care of these children. And one of the ways to minimize this is develop a smart shunt system that responds to average ICP. We have completed the design and prototyping several of these components, and now we're putting it all together and testing it. So there's been significant improvement in the care of children with shunts. There's been significant advances in technology, not the least which is endoscopy, that is eliminating shunts in a lot of these patients, but not in all of them. Multidisciplinary clinic and education is key to improve the overall day-to-day care of these patients. However, we've inherited outdated care, dogma, methodologies that are a thing of the past, and we can't accept those. It's our responsibility to improve on the care. It's responsible to care about the children, to teach and educate others about the problems that we're facing with these children, and educating ourselves and getting better and improving the system so that we can improve the care overall. I would like to thank the team that I work with, the clinicians, the physicists, and the engineers, as well as the funding agency, the BERMANS Foundation, that allowed us to do this work. And I would be glad to take any questions you have. Thank you.
Thank you, Benny. Thank you so much. It's a very interesting
yes.
approach to Shunt problem is a worldwide problem. So, and of course, we have a couple of questions, and you can open to the audience to do the questions too.
Sure.
And we have some problems in sound. Probably some concepts could be lost because of the sound problem, but we can talk about if someone has doubts about what you said. So, Benny, how to approach a patient with headaches, a chronic headaches with a shunt? So, the image sometimes all the time you ask for image, but you told us image is not the solution. Yeah. And tap the shunt. Probably in US, you guys tap more shunts than us in Brazil, so you don't have the culture to tap the shunt as you tap some patients in your clinic. So, but how you are dealing with the patient with chronic headaches, and you have some doubts if the shunt is working or not, one practical protocol for dealing with this problem.
Absolutely. And by the way, I see in the chat box, there were a couple of questions about
yes.
the topic, and I will get back to those, but let me answer your question first. This is, of course, the $64,000 question, Ricardo. None of us is great at taking care of these kids perfectly. I mean, there's no perfect algorithm or approach out there, but there is a safe approach. And the way that I do it is we have a team of nurses who are educating the families nonstop, which means that every patient who comes to my clinic, first of all, will have a yearly visit. If they're young, they come twice a year. If they're older, a yearly visit. They get educated on shunts. They get encouraged to call. They have our phone numbers. We tell them it's 24/7. No question is a stupid question. We tell them about endoscopy. We tell them about what the problems are with shunts, what CT scans mean, what MRIs mean, so that we make them comfortable to call us. Because that, as I showed you in the first part of my talk, is really the most important part of, this is the most life-saving measure you can do, is educating the primary caregivers, the patients and their families. That's number one. Number two, let's say a child calls with a headache. He doesn't have the flu. He doesn't have diarrhea. It's not obvious that this is something else. We bring him to the clinic if it's during the day, to the ER if it's at night. And we have a process. The process, we always get a scan first, because even though many of the scans will not show malfunction, every once, 2/3 of them, the scan will show a malfunction, or maybe over half of them. So that will make it easy to find out. If the scan shows a malfunction, then you can go through whatever algorithm your institution has, whether or not you tap the shunt, whether you get a shunt series or not, whether when you take him to the OR, that's based on your own preference. However, what you're asking is, what do you do when the ventricles don't dilate? How do you deal with that patient? Well, the next step for me is to tap the shunt. If the shunt tap, for example, shows that the pressure is really high and there's really good flow, that means there's a distal obstruction. That's easy. We got an abdominal ultrasound, we got a shunt series to look for disconnection. If the flow is normal and the pressure is low, then it's likely that the shunt is working. But in cases where a child who's not used to having headaches, we admit them for observations unless we know that family really well. Let's say you tap the shunt and you can't get any flow, or the flow is very slow. Then in that case, it's very difficult to know. It's likely the shunt is not working, or it's working intermittently, but it's possible also that the pressure is so low that you can't get fluid through the shunt tubing. In that case, if your clinical suspicion is high, if the child is really sick, he's getting bradycardic, the headache is getting worse and worse, then we take him to surgery and explore the shunt. However, if the child is stable and we're not sure, we either admit for observation And oftentimes the next day, they start having flu-like symptoms, and we know it's not the shunt, and we send them home. Or if we're concerned, we might put a ICP monitor in. And the ICP monitor will tell us what the pressure is and will make us more comfortable in this. Now, of course, ICP monitors are not 100% because there are some children who are used to very low pressures in their brain, but that's the minority. You will detect the majority of patients. I would say education is first. Seeing the patient face-to-face is second. Admitting them for observation is third. And then you take advantage of whatever system of management you have, whether it's scans, CT, MRI. Now, another question that someone might ask is, it's difficult for us to get MRIs at our institution. We're not a big hospital. How do you do it? And MRI is more expensive. How do you do it? Well, when we first came out with our data, what we knew that this problem was going to be an issue. So we made a special deal with the radiology department. And the deal was this. Because the scan takes less than a minute to do, which means the entire scan from the time the patient gets into the scanner to the time he leaves is less than 5 minutes. The radiology department committed that we get our scans within an hour of ordering them, no matter what. So they usually would have a patient, let's say a stroke patient on the table. The moment the stroke patient is done and the spine patient is next, they will get the shunt patient in between. It only takes 5 minutes, no big deal. And the second thing we did is they committed with the hospital to reduce the fee of the MRI so that they don't charge as much of as a CT. And this is how we got to be able to do these MRIs on those patients to try to avoid radiation.
Great. Benny, Ricardo, you have some questions too?
Yes, Benny, I have two questions. So first, it's an excellent, outstanding lecture. And as you told us, it's outside of the regular books. So it's very, very interesting for us. I think that this topic is it's still complicated after 16 years after discovery of the shunt. Is still complicated, this topic. So I have two questions. So one, if you have some protocol for to manage distal catheter when the child became adolescents, growing from the infants to the adolescents. And the second question is, do you think that the mechanism that you showed us could be a little bit different when you compare pediatric patients and adult patients?
Yes, absolutely, Ricardo. Let me address your first question first. So we put a lot of tubing in the abdomen when we put shunts in babies. So it's rare for them to outgrow them. We put at least 30 centimeters of tubing. Some general surgeons cringe at that, but it works. The second thing that we do is, the old barium impregnated valves that are really visible on X-ray, those white, not valves, but catheters. Those white catheters calcify, stick to tissues, and break. And I don't use those. What we use is the translucent catheter that has just one barium slit on it. It's not as easily seen, but it doesn't stick like the others. So these are the ways that we've avoided, major malfunctions. Now, in terms of the protocol, so you were asking about difference between adults and children. Well, first of all, as you know, when we put a shunt in an adult, the failure rate is very low. There's a reason for this. I think the reason, and this is of course observational, I don't have data, but I think the reason being is that the ventricles don't collapse around the catheter. They stay large, they're stuck that way. And that's why we have way worse malfunctions in babies than we have in 5-year-olds or 10-year-olds. The ventricles are less likely to collapse. The brain is stiffer, so it's less likely to just lose fluid and collapse. And so I think this is what makes the difference. Now, I still think, however, by overdraining adults, they will tend to develop a headache syndrome later on. And you and I, and we all have seen a lot of these kids grow into adulthood and develop a headache syndrome that no shunt revision will help. And that's, I think Ricardo De Gap also asked that question, is what about those chronic headaches? Well, if I put an ICP monitor and the ICP is between -5 and +5, I can't do anything. I can't take care of these headaches. Hal Recate published a paper a few years ago that said that 42 to 45% of children who grow up into adulthood or adolescence with shunts, 42 to 45% of those develop severe, debilitating, intractable headaches. What does that mean? Headaches that you cannot do anything about. Not the pain clinic, not neurology, not shunt revisions. Why? I think it's because they're losing compliance from over-shunting. I think that you're drying the brain cells, you're drying the intercellular space. Instead of having a wet sponge in your skull, now you have a rock. And every time you climb up the stairs, it's gonna rock. Every time the weather changes, it's gonna rock. It's going to, rock and cause headaches. I'm sure you've seen this, but I have patients that I can hang outside my house like a barometer, and they tell me what the weather is gonna be in the afternoon, because they can sense it. They don't have that compliance that we all have, the cushioning effect of CSF that we have in our brains. Let me answer a couple of the questions that are on the chat. So these are really good questions. And I think that the same answer comes for all three of these questions. One of them asks, why is it that an Orbis Sigma valve doesn't help if it's flow regulated, if it's not related to gravity as much? Well, if you think about it, every valve that constantly open is a gravitational valve. Whether or not its mechanism is different, flow regulated mechanism is still open to drainage 24/7, which means that, yes, the Orbis Sigma valve may decrease drainage a little bit, may make it a little more predictable, but can you guys still hear me?
Yes.
Yeah, but still, it's open, and it's going to drain every time you stand up. It's going to drain a bunch of fluid. It doesn't stop that. What you need is a valve that's closed until you need it to open, not a valve that's open all the time and is susceptible to all kinds of crazy pressures in the brain and differential pressure. So that's one. The second is they asked, what about adjustable valves? Well, if you think about it, adjustable valves take the best or the adjustable valve with the highest pressure on the market that I'm aware of is the Certas valve. It gives you 40 centimeters of pressure. They call it virtual off, theoretically. If you stand up and you're 178 centimeters, you stand up, you immediately have 60 or 70 centimeters of gravitational force. It's going to overcome any pressure that this adjustable valve has, whether it's 20, 30, or 40. So an adjustable valve isn't going to mitigate this problem. The third question is, what about the valves that already have an anti-siphon device attached to it? And I will tell you that these are all my own biases, and we're testing all of that now on the benchtop. So hopefully next year I'll give you more information that's more scientific, but I can tell you what I think. If you were to have two doors, maybe 2 feet apart, okay, and you kick one door open, the pressure there is going to second door open. When once the pressure of the air is going to open the second. However, if you have one and the other door at the end of the hallway, you kick the first door open, then the pressure cannot go 20 feet to the second door. It's already averaged. Does that make sense? Did you guys hear me because it interrupted for a second?
There was some problems, but I think everybody can understand you. The two doors open theory.
Yeah, yeah, yeah. I mean, this is how I see it, and I may prove it wrong later. But we are doing some benchtop testing to see if this. It certainly seems logical to me. And you know, if you look at John Kessel's randomized trial, where he compared the regular differential pressure valve with the delta valve that has an antisiphon with the orbisigma valve, he saw no differences in the outcomes.
And we have another questions from the audience, Benny.
Yeah.
So,
Angelo.
what, Angelo? Yeah. And so, Maset, do you want to ask the questions personally, or you can?
Yeah, I can read the chats.
Yeah.
Why don't we? So I'm going to read. Do you have experience with flow ICP reading devices such as the Mithki shunt sensor? I don't have experience with it personally, but I have seen it being used. My understanding about this is that the ICP sensor requires a fluid column to pass through it. So it's sitting along in series with the valve system, which means that if there's an obstruction in a ventricular catheter, you may not get enough fluid in that sensor to be able to measure the ICP. And I don't know, maybe you guys know more about it than I do, but that's my understanding of it. Another question here is the ependymal invaginations are also seen with gravitational valves? Absolutely. I've seen it with every type of valve. What are your thoughts on ETV at the time of shunt malfunction? You know, one of the reasons that I like to see my patients routinely every year is because I teach them about ETV before it becomes an emergency. Because when it becomes an emergency, you want to sit down and talk about the basilar artery, and we have this new procedure. They say, whoa, just revise the shunt. So I prepare all my patients so that when the shunt fails, absolutely, if I feel that there's a good chance that an ETV would work, we would offer an ETV first. What is your go-to valve for routine hydrocephalus? Currently, what I do is I put either a regular valve or a programmable valve and an antisiphon device 10 centimeters away from it. So a coronal valve and an antisiphon device. Now, previously, I wasn't a great believer in adjustable valves because when you try to adjust it, it didn't seem to correlate with ICP. However, ever since I started adding these antisiphon devices, I found that the programmable valves are more adjustable. They're more reliable. And I think it's because you're taking away some of that gravitational pull on them. But that's just an observation again. What's your approach to question altogether? I think probably Ricardo can answer this question because he's been, I know he's done some aqueductoplasties that we've done in the past. A trapped fourth ventricle, my approach is to go from below and open the foramen of Magendie, and if we can, open the aqueduct. You cannot, an ETV will not help it because it'll still be trapped. A VP shunt will not help it because they'll still be trapped. And excuse me, I don't believe in shunting the posterior fossa ventricle because it's prone with problems. What do you think if a shunt could attenuate the increased flow caused by P waves? I'm not sure what that means. Maybe the person can tell me what that means. How long after you install a shunt?
Do you want to?
I'm sorry?
I'm calling the Angelo to ask directly for you, Benny.
Yep, sounds good.
Professor, congratulations for this outstanding lecture. And we know that we have overdrainage when the patient is sleeping, and especially on the fourth level at the REM, at the REM sleep. And this is caused by the amplitude, pulse amplitude that changes at that point. So we have 10, 15, even 20 millimeters of mercury from diastolic to systolic.
Yes.
And all these shunts, even the top shunts, they do not consider that fact. And at that point, we have overdrainage. So that's why I asked that question. And following that, if I may, you think that shunt would be better stay non-functional and be functional if there is an increase in pressure, in ventricular pressure, if I understood. But don't you think that physiologically we have an extremely complex cerebral spinal fluid physiology, which requires a continuous interstitial cleanup for all these metabolites that we accumulate during the day, and even more at night when we have 3 times more increase the velocity to clean up this interstitial flow.
Yeah.
So don't you think the best physiological shunt should approach the physiology? I mean, continuous drainage without cause over drainage, and reproduce what happens in the brain.
I can't agree with you more. This is an excellent question or answer. Definitely, a passive shunt, for example, if you can shunt the ventricle directly to the sagittal sinus, for example, that would be so much better than a shunt that is where we have to fight gravity and fight pulsations. I think mitigating the B waves makes absolute sense. The question is how to do it. And the other thing, I agree with you that the CSF physiology is very complex. However, I will tell you that the problem is very simple. So whereas the CSF physiology is very complex, the problem is we are addressing it with a too simplistic of a shunt system, which is, I think, what you're saying. But the problem is simple. The problem is that we're draining too much. Now, if you start studying the CSF physiology with all the waveforms, that could be a very sophisticated study, and you can come up with much more sophisticated technology based on this. But we have to start somewhere. 60 years of using differential pressure valves, where the shunt obstruction rate is exactly the same now and in 1960, is unacceptable. We have to start somewhere. We're not smart enough yet to come up with a highly physiological shunt system. I started with these anti-siphon devices. I cut down my shunt obstruction rate by 70%. Huge. And we're not the first people who have done this. The Germans, there's a German group that published a paper in the Journal of Neurosurgery in 2000, where they added anti-siphon devices into their shunt system and decreased their shunt obstruction rate by 90%, even better than our data. I don't know why they're better, but they're better. So we do have simple solutions that we can address now. You know, of course, the second step is a smart valve. The third step is what you're saying. But we have to go stepwise. But we can't stop. We can't stop with anti-siphon devices. We can't stop with smart valves. And the only way to really improve it is to start making a great effort to understand the pathophysiology. If you look at the research that is being done with shunts in the past 2 decades, you find that research on how to make smaller holes in the catheter to prevent obstruction, research on how to position the catheter. Do I put it coronal? Do I put it occipital? Research on, these studies are not based on pathophysiology. They're not based on a hypothesis. What is it that's driving shunt malfunction? So absolutely, what you're saying is all true. The last thing I would tell you is, I don't remember who said this, but he said, every complex problem has a solution that is simple and wrong. So, this could all be wrong, right? But what have we done in the past 60 years to improve things? Not much. And that's why I say, let's just start somewhere.
Yeah, if I may, again, I agree with you. And I still see a lot of misunderstanding among neurosurgeons of what is the definition of an anti-siphon device and an anti-gravitational device.
Yes.
They work differently. They have different outcomes. And both are from 73. Now the German, the mythic valve is actually is from Hakim from 1973 for a lumbar valve, right?
Right.
And that was the best design that at least I consider so far that we had to reproduce the physiological resistance imposed by the CSF flow.
Yeah, yeah.
And I agree with you that there are so many small details still to go on, and that this discussion will be for the next 60 years for shunts, because for shunts. Did you use a RFE, or do you use battery, or there's no battery in your system?
No, there is a small flexible battery. It looks like a postage stamp, and it's rechargeable.
It's a passive element.
It's a
rechargeable. Okay.
It's charged by RFID. Yeah, radio frequency charger.
Yeah.
Yeah.
Okay.
Now we don't have the whole.
Well, thank you very much.
Absolutely. Thank you for the question. So there's another question here. Thank you. How long after you install a shunt you ask for image to see if the ventricles are too small? Usually my first image after shunt placement is at 3 months. That seems to give me a good baseline. And since I usually now put an anti-siphon device at the time of the first surgery, I try not to put then I might start to try to be more sophisticated with it, maybe try to change the programmable valves. Maybe I actually have a few patients that have 2 anti-siphon devices. In fact, I was at an ISBN conference a few years ago where I saw a poster from Germany where I don't remember the name of the surgeon, but he had used a MISKI ICP sensor, and then he started adding anti-siphon devices into the shunt system of this teenager that was having a lot of problems. And he got her to be symptomatic after 5 anti-siphon devices. Now that seems to be crazy if you think about it, but it just shows you that we just don't understand, just like Angela was saying, we just don't understand what the physiology is and what the pathology is. And it's important to start working on this. There's a question here from Andre Kiss. What's your main criteria to consider a chronic hydrocephalus as arrested? You know, that's a very difficult question. I'm not sure if people who grow up with hydrocephalus from childhood really have arrested hydrocephalus. I have seen 50-year-olds who have had hydrocephalus most of their lives, and they start to deteriorate cognitively and neurologically when they turned 50. I don't know why, but we have to be very careful when we make a diagnosis of arrested hydrocephalus. It's a very complicated question.
Benny, are you studying something about choroid plexus coagulation? Do you think that could help anything to your patients?
That's another hard question, Ricardo. You know, obviously it's helping some patients. It's helping babies. It's not helping older patients, and we don't know why. If you look at the history of choroid plexus coagulation and the science behind it, it doesn't make a lot of sense. Because, for example, there was, in the 1960s or 70s, there was either a Science or Nature paper that showed that they coagulated the choroid plexus. I think it was Millerite that did it. Coagulated the choroid plexus in monkeys and found that the more drainage you do, the more CSF production you have. So it's difficult. Plus, some people tell you that the choroid plexus is not there to necessarily produce CSF, but it's more to control the vascular environment. Some people tell you that the ependoma secretes CSF. So we don't know. One thing I will tell you, though, about choroid plexus is for many years we've been taught that choroid plexus is the cause of shunt obstruction, and it's not. Only about 15% of the shunts that fail have choroid plexus in the catheter. But I will tell you this, every one of those, the choroid plexus was sucked into the catheter through overdrainage. And if you think about it, when you put a reservoir and catheter for someone with cancer or a preemie, to tap the valve, have you ever seen one of these catheters obstruct? They don't. Why? Because you're not asking them to drain. Every once in a while, you take the excess fluid or you inject chemotherapy. They don't obstruct.
Dr. Sergio, Dr. Benicio, do you have questions for our?
No, I don't have any question, but just thank you, because you really was amazing, because you spoke things that I repeatedly say to residents, specifically when you said that the mom is always right. And that's a good thing. Thank you very much.
Sure. Actually, there's a study that shows, I can't quote it now, but that when you ask moms if they think the shunt is working, if the shunt is not working, they're more than half the time they're right. If the shunt is working, more than half the time they're wrong. So, but at least we take them seriously.
Okay, I have a question. Nice presentation. When you try to do a neuroendoscopy after shunt, after several years, and you have a frontal catheter, you try to remove it and put the endoscope through the same way. Yes. Sometimes I think it's bleeding more than the normal. You have some truth to that because I think there is some adherence, something. I'm worried to do the endoscopy for the same way of the shunt. What's your opinion?
Absolutely, that's a great question. Thank you for asking it. What I do, what I developed over, and you know, one thing I think you might understand this as much as we do. When I was a chief resident, is when endoscopy was introduced into neurosurgery, which means that in residency, we had no training in endoscopy. It's all, we all learned on our own. And so you develop these techniques by trial and error, and hopefully we haven't hurt a lot of patients doing it. So I'll address this particular one. So if I have a coronal catheter and I want to do an ETV, what I do is I leave the catheter in because oftentimes they're stuck and I don't want to cause a hemorrhage. I enlarge the burr hole around it. Then I take a small scope and I have a Bugbee wire or a monopolar cautery at the tip. The catheter is enveloped by an inflammatory membrane all the way along it. So I take the Bugbee wire and I split the membrane around the catheter all the way into the ventricle. It opens up the channel with very little bleeding usually. So that's what I do. Now, the first 2 centimeters, you could probably do it with the bovie, just with your hand. But then later on, when it gets into the depth, you really need to do it with the endoscope.
Okay.
I don't know if that answers your question, but that's what I do.
Okay, yes, good. Thank you.
So, do you have any no more questions for the audience? Manny, I think you solve all the problems for us.
I think I created more questions than answers.
Yeah.
Final answer.
But do you think that this new system could be in the market how many years? Is it possible to, the technology will develop so fast to do that?
Yeah.
And the price will be so expensive?
Yeah. So Ricardo, we've been working on this for about 7 years, and we just started the company, and we're just looking into the business model, all that unfortunately we have to look into. It's it's never been on my radar. I'm not a business person or an entrepreneur or anything like that, but so I'll answer it 2 ways. All goes according to what our predictions are based on our market study. The valve would not be that much more expensive than a programmable valve. And in fact, over time, if it works the way it's built, it will save way more money in the future than what the valve would cost. And you can imagine if you change the valve every time a shunt malfunctions, and the shunt stops malfunctioning, or maybe you just need a battery change every 5 or 10 years, then you've gained long term. However, I will tell you truthfully that I don't think an electromechanical valve, which is what we've designed, is the solution. I mean, just like Angelo said earlier, you need something more sophisticated, more physiological, more passive. I think when I first started this, when I put the engineers together and brought funding, I told them, look, I want you to call NASA and GE and the big corporations and Department of Defense, find out what technologies there are out there that's amazing, that could give you microfluidic, drainage that is controlled. What they came up with is an electromechanical device, which, if you think about it, is 1970s, 1980s technology. So what I'm hoping with this is to raise awareness. Whether or not the valve that we're designing works, the whole idea with this valve is harder and be challenged to develop technology that's going to be better than what we have now.
Okay. Ricardo?
Okay, thank you. Ernie, thank you so much for your outstanding presentation. Very nice, very exciting topic.
Thank you for the invitation. I've never been told a shunt topic was exciting, but thank you for that.
Yeah. Yeah,
Sure,
the
it
shunt is
helped
always
a
a
lot.
problem.
Yeah.
Okay.
All right. Take care. Thank you.
Thank you,
Thank
Benny.
you. Thank you.
Bye-bye.
Bye-bye.
See you.